I'm going to talk today about the limping child, but really the limping toddler. And if you have any questions at any point, please raise your hand, interrupt me, stop. We'll get into a discussion. It's way better when that happens. First of all, how many of you have seen one of these kids recently? A kid that comes in, say 3 or 4 years old, not really walking, with no apparent explanation. Okay. All right. How many of you enjoy taking care of these kinds of cases? Yeah, right. Why not? Yeah. Why not? Parents, right? You've got a parent that's been on Google, and they're like, they're all Googled up and wired up on coffee, and they're freaking out, of course. But a lot of, parents are, sometimes difficult. But I think there's a bigger issue here. So what is the terrible diagnosis that we can't miss? Septic arthritis. And how many of you have seen a case of septic arthritis in the last 15 years? Got 1, 2, all right. Ooh, 3, actually pretty good. Pretty good. How many of you have have worked up patients to the hilt for septic arthritis only to find out it was a benign condition? And that happens a lot of the time. So this is a classic emergency medicine case, right? You've got a rare diagnosis that's very serious, and a common diagnosis that is not very serious with huge symptom overlap. And then you overlay on top of that a Googled up parent. And then you overlay on top of that the way to get to this diagnosis is not particularly easy, right? It frequently involves orthopedists, pediatric orthopedists, needles into hips, things like that. All things that in community practice are really, really difficult to obtain, right? So we're going to try to look at this and see where the literature takes us on this, maybe get some recommendations about how we can approach these kids in a rational way, if that's even possible. To help us try to differentiate these kids with the benign conditions like toxic synovitis or transient synovitis, and septic arthritis or a couple of the other cousin diseases that are also serious and that we need to be aware of. So without further ado, I would just admonish everybody to remember with the kid, I guess the other piece of it with the kid isn't just the parents and stuff, but you've got a 3 or 4 year old and you're trying to talk to them about a history. Right, because it's so, it's subtle. Did you fall? Did you have this? And they're talking about their Beanie Boos and everything else. You're trying to, get them focused. And so the lack of reliability in the history throws another layer on top of all of this stuff. Kids fall all the time. They don't remember, et cetera, et cetera. Okay, so let's move on and go straight into abstract number 1, characterization of transient synovitis of the hip in children. So for many, many decades, this was called toxic synovitis. I have no idea why, okay, because it does appear to be a synovitis, so that part I get. The toxic part is the squishy part. In general, this is not thought to be toxic, at least today. I guess at some point in the past there was concern that this disorder led to further complications. It's always been known that when the kid is not very sick, they have this self-limited disease, but there was a concern that it led to avascular necrosis or other issues that we couldn't explain, the leg calf Perthes disease that we have no idea why it occurs, and some of the thoughts were that it occurred as a consequence of this. So this is a relatively older study, but it's also relatively large. It says 500 kids were followed for a long time, and what they found was, this is a huge series, took 30 years to acquire these 500 kids, and they were all acquired between 1952 and 82, so it is old data, but nonetheless, it's a huge series. And what they found was the total duration of symptoms for these kids with what they diagnosed as transient synovitis was, as we'd expect, very short, a week, 10 days on the high end, all right? And the recurrence was extraordinarily rare, and that's recurrence of transient synovitis. Only 19 kids out of the 500 had a recurrence. It's actually one of the conditions we think of as sometimes having recurrence, but in this particular case, less than 3%, around 3% had recurrence. So very low rate of recurrence. And somewhat surprisingly, they did find an occasional case of leg calf Perthes disease, so avascular necrosis of the idiopathic avascular necrosis of the hip on multi-year follow-up of these children. So it was only 3 cases out of the 500. They only had great follow-up for about 120 of the cases, so 3 out of whatever the denominator, but somewhere in a percent or so of these kids may progress. That is higher than the population average, but it's still very low. So I think if you're thinking about this disorder and still wondering, is it associated with long-term sequelae or anything like that? I think the answer is overwhelmingly no, with the slight caveat that maybe 1%. I feel I sort of talk about it when I talk to parents as the way I talk about febrile seizure. Sure, it's generally really safe. Your risk of developing epilepsy long term is a little bit higher than the general population, but I keep that to myself. I don't think they need to necessarily know that because it is so small. So overall, we have evidence that this is, in fact, not a toxic disorder, but a transient disorder of limited clinical consequence. There's a second article, number 2, which is basically pretty similar. It's just much more recent. It's a Scottish study, 103 kids. They had better follow-up. They followed them for a long time, 7 years on average. Over 80% of them had that 7-year follow-up, and they had none of these 103 kids had any long-term consequences. So again, just some reassurance that this is a benign condition. If you miss it, or if you think the kid has nothing and you send them along, or you tell the parents everything will be fine, chances are that they will be fine, provided that they have transient synovitis and not something like the more serious conditions. Okay, so now let's talk. So we've established that transient synovitis is benign. Is septic arthritis serious? Well, it says septic, but the other one said toxic, so I'm not willing to go on face value. So this is just a small study from Saudi Arabia reviewing cases. It's a case series of people who were proven to have septic arthritis on hip aspirate. It's a retrospective. The methods aren't great, but there's not a lot of data on this. It's a relatively rare condition. It's hard to find cases. And so they looked at this. They looked at their case series. And what they found was, some of the basic bacteriology is there's a lot of mostly staph and then some enteric gram-negative organisms like we'd expect, because the typical way of one acquires septic arthritis is either through direct inoculation, hematogenous spread, and then often, or occasionally at least, intra-abdominal pathology spreading into the hip joint. So they found a lot of staph and a few cases of enteric gram-negatives, typical stuff. But what was notable in this study is that they found that if there was a delay of treatment, there was a huge difference in outcomes. Okay, so after 4 days, so treated prior to 4 days of symptoms, people almost universally had excellent recovery. 95% of them had great functional recovery. Again, the methods are a bit limited. It's hard to tell exactly, how great this recovery was. They didn't use standardized scales, et cetera. But they thought that everything did really, really well. If the delay of diagnosis the delay to treatment was more than 4 days since onset of symptoms, then the kids did really poorly. Now, the delays were often a couple of weeks and stuff like that, but where they drew the line in the sand was at 4 days, which is probably somewhat arbitrary. But nonetheless, if you went out, if there was a delay, if you missed it, there was a lot of problems. A lot of the kids went on to become septic. A lot of them had functional limitations in the long term. And they actually report that only 16% of those cases had a good outcome. Now, I'm sure these data are a little skewed and messed up and everything else, and I don't think we should, think that at 4 days, all hell breaks loose, and less than 4 days, everything's great. Nonetheless, I think that this establishes that there is a pretty significant time sensitivity to this disorder, and that it is serious, as opposed to transient synovitis that, apparently is not serious. So now we've established what we started with. We got a rare disease that's super serious and a common disease that's not so serious, and we're going to talk a bit about the symptom overlap in just a moment. Before we move on to that, there's just a few other conditions I think we should talk about in the limping child. One of them is highlighted in abstract 4, I think. That sounds right. And the question is, how are the demographics of Skippy, or sometimes called SUFI, slipped capital femoral epiphysis, different from septic arthritis and toxic synovitis? So, who's seen a Skippy case recently? All right. You want to tell us about it? What happened? Just a hip pain case. Was there any trauma? No trauma. Okay. So Skippy is a bit different. The demographics are clearly different. Whereas toxic and transient synovitis occur in 3 to 6-year-olds, these kids that can't, want to talk about their Beanie Boos and stuff like that. This other stuff occurs in 12-year-olds, kids who, if they're a girl, want to talk about, the preteen boyfriends and stuff like that, and if they're a boy, want to talk about baseball. So these people can give reliable histories, but it's a very different demographic. These occur at the time of maximal growth, so it's around 11 to 13 years old, depending on if it's the gender of the child. So this one happens later. It often is atraumatic and chronic. So that's the classic history is the kid shows up in their pediatrician's office with hip pain that's been going on. It's boring pain. It happens that it is occurring all the time, and it's been going on for about a month. Where we tend to see it in the emergency department is a child who's had some vague symptoms in their hip, and then they do something, and they injure it. So the most recent case I saw was a 12-year-old girl who was a softball player who had been having a little bit of pain, but she was an active softball player, so she sort of thought, I'd strained a muscle or something like that, slid into home, and then couldn't walk. Right? And that's a classic emergency department presentation of these children. Vague pain to begin with, pretty much going along their daily business, and then with a relatively minor trauma, they take what was a slipped femoral epiphysis that was just slightly off, and then rip it off completely. Now, there's some terrifying images in there of, I think there were at least at one point, that showed at presentation and how quickly this can degenerate, but that's not the norm. The norm is that this is a chronic condition. Nonetheless, once you make the diagnosis, you'll have to move on. The things that are you'll have to refer them to a pediatric orthopedist probably that day, could be the next day, depending on how reliable the follow-up can be otherwise. Yes, sir? Yes, absolutely. But they can be made non-weight bearing to follow up. So you could, what's that? Oh, yeah, we have wheelchairs, things like that. I think that, no, the point is well taken. I think in general, when you make the diagnosis of Skippy, and you see in that image that you can progress from a minimal slipped capital femoral epiphysis to a full-on, the femoral epiphysis is off completely, relatively quickly, and in general to be a non-weight bearing status. I think there's probably a role if you're far from your the orthopedist and the follow-up is pretty reliable, that they can go in a wheelchair to where the children's hospital or whatever, get on a plane or something like that. If they're, on vacation, they got to go an hour or something like that. I think that that's a reasonable approach. Although in general, yes, you can make a case that this is something that needs to be dealt with emergently by an orthopedist. Again, that's a systems-based practice as opposed to a medical-based practice. It just sort of depends on what system you're in. Things that are associated with delays to diagnosis and misses, that's really the topic of abstract number 4. Is that, first of all, it's as one would expect. Okay, first of all, the delays of diagnosis are very common. Some of these kids in this series of 196 kids with Skippy, some of them were diagnosed 100 weeks after their initial presentation and initial symptom development. So it can be a long time. On average, it took 8 weeks to diagnose them. So it goes against this idea that they have to be non-weight bearing. I mean, they were running around for 8 weeks on this thing. But once yeah, I think, the onus is on us to say, hey, no weight bearing, get in there, very, very quickly. And sometimes you'll get fooled, and what they suggested is when the pain is located in the knee, the kids are walking around and they're just complaining of boring knee pain. We all hear about it frequently. Think about the joint below. This is one of those situations. If you have someone who's in the range of in that age range, 11 to 13, constant knee pain, consider the diagnosis of Skippy. If you don't, you're going to miss it, which may well be within the standard of care to miss it, but within the standard of doing the best you can, try to think about that. Maybe it'll highlight it and you can pick this diagnosis up before it causes any consequences. All right, I think that's all I want to say about Skippy. Are there any other questions about it? Cool. So let's move on to abstract number 5. And this is essentially getting back to our child, the 3-year-old-ish, who comes in unable to bear weight. Now, we're talking a lot about transient synovitis and toxic synovitis in this chapter, but there are a couple other conditions that we should think of. In the atraumatic one. The traumatic one, the kid's leg is bent backwards. We don't, that's not much of a diagnostic dilemma. But it is not uncommon for toddlers to develop small fractures that render them weight-bearing after very innocuous injury or no apparent injury. You've all seen these cases, I presume. And what kind of fracture would we call it? Toddler fracture, yeah, it's convenient. And you see them, they go down the slide, and it seems like nothing, and mom says he just wouldn't get up afterwards and cried. And there's no mark, there's no bruising, there's no nothing. So the question is, when one of these kids comes in, non-weight bearing, is there any utility to doing a bunch of x-rays of their leg before you start trying to figure out if it's in their hip? And abstract 5 gets at that a little bit. It's a very difficult to sort of work through abstract, so I'll just kind of summarize it as opposed to trying to go through the methods. But in essence, what they suggest is that you get the same yield if you just take an x-ray of the tibia than if you x-ray the whole leg. Okay, so they're saying in these children that sort of fit the profile of a toddler fracture, no serious trauma occurred that anybody saw. Maybe they fell down, came off a swing, whatever, but nothing that was dramatic, that there's very low yield in looking for femurs, looking for feet, etc. That the toddler fracture is present frequently. They say between 10 and 17%, but nothing else is, it's almost universally that fracture. They found one other metatarsal fracture. So you'll have to decide for yourself if you want to go ahead and baby gram them. I mean, if it's easy to if the child is small enough and you can get them on one plate, it may be worth doing the whole leg, but the yield is going to be on the tibia, which is typical place for a toddler's fracture. They're typically at the junction of the middle and distal third of the tibia. They can be transverse, oblique, etc. They're almost never displaced, and often they're invisible, unfortunately, for us. So if you got a kid that's tender over that area and the x-ray is negative, or you see something that you think might be a nutrient vessel or something like that, you can go ahead and put that child in a splint and then call it a toddler's fracture, and that would be well within an acceptable standard of care. Very little utility in looking elsewhere. The one thing that is sometimes talked about, it's in textbooks, etc., is if the child so we've got the child that won't walk. If they crawl around on their knees, where's the injury? So they won't walk, but they crawl on their knees. Where's the injury? Lower leg, right? So it could be still a tibia or a metatarsal, but if they're doing that, look for, you got a kid that used to walk and now he just won't, but he will crawl. There's a lot of pressure put on crawling into the hip, so that tends to argue away from the hip and towards the lower extremity. In that situation, I think I probably might x-ray the foot too. I mean, most of the time they just won't walk or move, so you don't get so lucky. But if that's the case, think about the lower leg. Okay. The next one gets at a cousin of the toddler fracture, which is a non-displaced mid-shaft femur fracture. Now, how many of you have seen these kids? It's a 3-year-old kid, 2-year-old kid, and they've got a femur fracture for no apparent reason. Yeah, I mean, I've seen it. This actually happened to a friend of mine, their child. And so this is child abuse. Okay? Well, the answer to that is it's probably wise to think of it as child abuse. Okay? And I think that this is this falls into that, that big, bucket of diseases where we say, hey, I'm just a simple ER doc, parents. There are diagnoses that when I see, I have to report. I make no judgment on whether it's child abuse or not. I just have to report it. Somebody else will figure out if it's abuse. And I think that a mid-shaft fracture of the femur is probably one of those conditions. But actually, interestingly, abstract number 6 sort of looks at a big series of these femur fractures. It's 139 kids, all aged less than 4, that have these things. And what they found was 42% of the time it was abuse or either confirmed abuse or highly suspicious for abuse. It's, you have to get through all these Child Protective Services records, kind of hard. But they thought that it was abuse ultimately after full case review, 42% of the time, when the child was non-weight bearing. Okay, it was non-walking. So if it was a baby, if it was a child that was 12 months old or something like that, then they thought it was abuse about half the time. So that's a slam dunk, got to report it, be careful. However, when the child was already walking, they found that it was abuse only 2% of the time. So this disease, we think of femurs in adults as a bone that is really hard to break. You need to be in a massive car accident to break it. In children, that doesn't appear to be quite the same. Now, I caution everybody, just know these facts. You'll have to choose your own adventure on this one. If it's a child that doesn't walk, I think it's a slam dunk. Report to Protective Services for the sake of everybody's sanity, and just tell the parents, I don't know, but this is one of our diseases that we have to. If, on the other hand, it's a child that's running around, there was some, vague fall at the park, someone saw a fall, everything else is consistent, I'm willing to say that this is a reasonable explanation for this. They don't have to have been in a car accident. 2% risk according to this paper. But you'll have to use your judgment and the reliability of the history and the parents in this. All right, so how useful are x-rays in helping us with the limping child where we suspect hip, though? All right, so Hip, this is abstract 7. Now we're moving past all these other fractures and getting back into our hip area. This is a New Zealand study. I guess we have some Kiwis in the audience. This fairly young kids, pretty large study, 300 consecutive children. They were all about 4 or 5 years old, and they looked at x-rays on all of them and said, how frequently did we get any utility when we suspected hip pathology out of these x-rays? And you won't be surprised to find that it was extraordinarily rare. Extraordinarily rare. 99% of them had an x-ray, 3% of them had a radiographic abnormality. The radiographic abnormalities were Skippy, and I think they had 1 case of avascular necrosis. Pretty uncommon. They go so far as to suggest you shouldn't order x-rays in these children. It's too low yield. I think that's maybe an aggressive approach. I'd probably still get an x-ray with a child where they have hip pain, just let's make sure that they didn't have an occult fracture, one of these femur things, something like that. But expect that it's very, very low yield. So if you're counseling a parent about this, you're saying, okay, we're going to go through this diagnostic workup, and they think you're going to get an x-ray and then tell them what the problem is, you should probably precondition them to say, I'm going to get an x-ray because it's part of our workup, but it's very unlikely that we're going to find anything that helps us. And then we're going to have to move on to other modalities to try to sort out what's wrong with little Johnny.
Isn't that a little bit of a odd recommendation when, if we're going down this road and we're going to elicit an orthopedist to be involved, can you fathom consulting an orthopedist without an x-ray?
Oh, I'm not arguing for, yeah. Oh, yeah, they can't even see a child with it. Yeah, they're unable to see a child. I mean, they put the x-ray up against the kid, and they're like, okay, well, they can't do that anymore, but because everything's packed. But yes, you're absolutely right. I do think it's an aggressive and sort of crazy recommendation. I think, so I'm trying to pull their recommendation back a little bit and just say, just so that everybody has the same expectations, the x-ray is going to be normal. And you shouldn't stop your workup in those situations. And the parent shouldn't think that then when you get an ultrasound or something else, that, oh God, something must have shown up on the x-ray. That's where I would lead. That's how I interpret this particular abstract. Abstract 8 looks at the utility of ultrasound in this disorder. So you got a bunch of hips. You say, okay, we got to try to figure out if there's septic arthritis. I heard that septic arthritis is an inflammatory condition. Surely the ultrasound should be able to pick it up. So they looked at a whole bunch of kids, 500 consecutive kids with non-traumatic hip pain, and they did in fact find 7 kids that had septic arthritis. That's a little bit low. Usually it's about 3 or 4% of these series have septic arthritis, just to sort of color where you'll be in caring for these children. And they found that ultrasound picked up all of them. So it was 100% sensitive for detecting a big effusion in those kids. The problem is that though it's 100% sensitive, it's very nonspecific. So there are only 7 kids with septic arthritis. They had 235 positive ultrasounds. So that doesn't help us a ton. I mean, it could potentially rule out maybe a half of the cases, and that's not bad. I'm not going to complain. It's better than still having to deal with, the full complement of kids. But it doesn't get us out of the woods very well, this ultrasound, and it's very nonspecific, albeit somewhat sensitive. So abstract 9 is more of the same. It's a systematic review saying that x-rays miss the effusions most of the time, 80% of the time. Ultrasounds pick them up almost 100% of the time. But then you're left with this issue of transient synovitis also produces effusion most of the time. And so you're still stuck with a huge number of kids that have a benign condition and a small number of kids that have the serious condition, and how are we going to differentiate that? Abstracts 10, 11, and 12 add another imaging modality into this mix, MRI scanning. So they say, well, septic arthritis is frequently associated with osteomyelitis of the femoral head. So what if we tacked on MRI and said, will that help us figure this out? These studies are all pretty flawed, to be honest with you, and it's hard to take too much away from them. And they are all universally very positive towards the use of MRI, but the inclusion and exclusion criteria limit our ability to use it routinely. We don't know how it would have performed in kids that were totally well. It's typically, in these 3 studies, used in kids that have a very high risk for septic arthritis. They're febrile, they're very irritable, high inflammatory markers, etc. I think the last article suggests probably the best situation, and this is an odd article describing discitis in children, and I wouldn't really put that on your differential. But the point is that if you have high suspicion, and if everything else is turning up negative, even the ultrasound doesn't show a fluid collection or something, consider an MRI, because there are other things that the ultrasound may miss, and that includes pelvic pathology, lumbar pathology, and sometimes abdominal pathology. So that's what their sort of take home on the use of MRI is. And I think that's reasonable, but it doesn't help us very much in the routine, relatively well-appearing child with suspicion for septic arthritis. So the last, not last, but the next 4 articles, 13, 14, 15, and 16, try to give us some clinical characteristics that might help us differentiate between these two things. Okay, so this is basically a labs. Do labs help us figure it out? So our inflammatory markers like ESR, white blood count, presence of fever, will those things help differentiate between transient synovitis and septic arthritis? So you do the ultrasound or you get the lab test, whatever, and you see an effusion. Should you then tap that joint, or can you rely on the labs being normal, the white counts negative, et cetera, to say, you know what, this kid is fine and he doesn't need it. We'll just send him home with Tylenol and he'll be fine in a couple of days, and we don't have to worry about the delay in diagnosis leading to a permanently limping child. The data's a little mixed here. But I think in the end, what we're going to come up with is it doesn't work very well. So the first 3 are sort of derivation studies. They're trying to find a rule. And what they find is, not surprisingly, that these inflammatory markers are associated with the disease. If you have a high CRP, much higher risk of having septic arthritis. If you have a high white count, much higher risk. The odds ratios in some of these are like 20, so 20 times the odds of having it. If you mix them all together and stir them up in a pot and come up with the best possible one, Abstract 15 says that you can be 98% sensitive. So you only miss 2% of septic arthritis cases, and you can argue whether 2% is acceptable to you or whatever. So they say this rule is the one. It's fever by history, ESR greater than 40, elevated white count, and then that the child can't walk. So that, as opposed to limping, the child truly can't walk and has these other 3 characteristics. That's the one. If they have none of those things, then it's really low risk, and they go so far as to say you could probably send those kids home. Okay? So that's an aggressive approach. Unfortunately, Abstract 16 said, well, let's take a look at that. Let's go ahead and use those rules on a validation cohort. And what they found is that if you have none of those kinds of risk factors, ESR, white count, et cetera, the probability of septic arthritis in their particular group was still 17%. Yeah, now they had a really skewed population. They had a really high prevalence of septic arthritis. It was 50%, which is super weird, way higher than the normal. But in this high-risk group, they found that these combinations and constellations of lab tests did not get them out of the woods, and they recommend against using them. So I would recommend against it too. The Abstract 17 proposes a diagnostic strategy that seems viable in a lot of places. It may be difficult to execute in some circumstances, but it's basically aggressive approach where you go in, you do the blood test, do the x-ray, and then do a sonogram. And they talk about their protocol. They slap EMLA on the anterior thigh crease while they're doing the blood draw. Okay, so as soon as that blood draw comes back, or as it's cooking, they take them to ultrasound, they look under ultrasound, they immediately tap any effusion. Now, I know that's going to be hard to organize. I get that. but that's their approach, and what they find is that like 90% of the kids had symptom resolution with the tap. They got the diagnosis all the time with the tap. If the fluid wasn't cloudy, and the gram stain was negative, and the inflammatory markers were legit, were calm, they sent the kids home, and the kids that they did that with were well. They didn't have any problems with. So they did a really aggressive approach. They incorporated all of this stuff, x-ray, ultrasound, inflammatory markers, and tap, and sent them home. Unfortunately, there's no literature in here that's going to support an approach that doesn't involve the tap. Now, in your clinical judgment, there may be someone that's super benign, et cetera, that you want to send home. I can't argue with that, but you're going to be kind of outside of the literature if you choose to go down that pathway. So everything is pointing towards you can do your best, you can do your best, you can do your best, but at the end of the day, the tap is the answer. Okay?
Who was aspirin
In this particular case, it was radiology. So they did the ultrasound and aspirated the hip. So interventional radiology, yeah, which may or may not be what your interventional radiologists do and your institution does. The last couple articles are just about some odd little tidbits about treatment. If you have septic arthritis, one of the articles suggests dexamethasone is a useful adjunct, and it's a Costa Rican study, and they say that it's great. That has not been endorsed by orthopedic surgeons in America, although it is discussed. So anyway, just know, if someone says something like that to you one time and you're not familiar, it's not completely insane to say, hey, let's add dexamethasone to the antibiotic regimen. And the final one is if you have transient synovitis, how do you treat the kids? And it's a simple randomized controlled trial in our literature that suggests that Tylenol and Motrin actually result in a much more rapid resolution of symptoms. So it suggests that that should be routine care for kids with transient synovitis. I'm probably over time because I see Sanjay Arora in the back. Hey, Rick went over time too. And so I will conclude there. If you have any questions for me, grab me in the hallway. I'll be around all day. We'll be talking up here on the panel. It was really nice to meet you all this morning.